Hi guys, in this video we're going to have a look at an overview of the nerves supplying the extraocular muscles, look a bit about cranial nerve 3 palsy and how that presents and what some of the causes may be, and then we're going to look at extraocular muscle actions, because that's often the thing that people struggle with, how to understand this properly. So here we've got a diagram from Morinaga, clinical anatomy, showing the three main nerves supplying the extraocular muscles. So we know this from preclinical medicine. So the orange represents cranial nerve 3, the oculomotor nerve, and that supplies the levator pulmonaris superioris, the superior rectus, the inferior rectus, and the medial rectus. And we have here cranial nerve 4, the trochlear nerve, that supplies the superior oblique, you can see here with purple, and the green is the abducens nerve, which supplies the lateral rectus. Remember that cranial nerve 3 has both somatic motor fibers, somatic motor fibers, which come from the oculomotor nucleus, which is in the midbrain, and it also has visceral fibers or parasympathetic fibers. So visceral fibers, which actually originate in the ending of Westphal nucleus, and they join the main oculomotor nerve, and that's this ciliary ganglion here. That's where the parasympathetic visceral fibers are going. So all three of these cranial nerves, just like all the other cranial nerves, originate in the brainstem. And we'll take the example of the oculomotor nerve. Originates we're going to focus on the oculomotor nerve because of cranial nerve 3 palsy. So the oculomotor nerve originates in the midbrain. So the oculomotor nucleus and the EWN supplying the visceral fibers, and then goes in the subarachnoid space, pierces the dura, enters the cavernous sinus. So this is the cavernous sinus here. So the cavernous sinus is sinuses are located either side of the sella turcica, which is the little sac which the pituitary sits in. So either side of that is the cavernous sinus, which have the internal carotid artery, the oculomotor, trochlear, and abducens nerve, and a couple of branches of the trigeminal nerve. So once it traverses the cavernous sinus, it then exits the cranium via the superior orbital fissure, which is here. And then that supplies the extraocular muscles through a common tendinous ring. This is the inferior orbital fissure. So that gives you a good overview of the course. This is another simplistic diagram from Teaching Me Anatomy showing the branches of the oculomotor nerve. So remember, it has a somatic motor fibers indicated in yellow, supplying superior rectus, levator pulmonaris superioris, inferior oblique, medial rectus, and inferior rectus. The visceral fibers also travel with it, but then divert and go to the ciliary ganglion to supply the sphincter pupillae and the ciliary muscle. So this is just another diagram similar to the one we've seen before, showing the various structures. So this is our ciliary ganglion, which we have the parasympathetic fibers coming off. And just for some orientation, this is the trigeminal ganglion here, so that's cranial nerve 5, branching off to the ciliary branch, ophthalmic branch, etc. So cranial nerve 3 palsy. The cranial nerve 3 palsy, oculomotor palsy, will often present, is seen in this patient, the eyelid is being pulled up because of ptosis. Ptosis is the drooping of the eyelid, and this is because the levator pulmonaris superioris, which is here, which is not working, so it can't lift up the eyelid. The eye is also down and out, as you can see, because the actions of the superior oblique and the lateral rectus are unopposed. And there is mydriasis, so dilation of the pupil, because of the parasympathetic fibers supplying the sphincter pupillae. So the dilated pupillae muscles are not being opposed by the sphincter pupillae muscles, leading to dilatation. You can see that's dilated more than this one. In terms of the causes of cranial nerve 3 palsy, we can divide them by, we can look at the anatomy of the course of the oculomotor nerve, and we can look at some of the causes. So if there was a lesion in the midbrain, for example, a stroke, and you can see here, this is a lacunar infarct, this grey diffuse lesion here, that is a lacunar infarct in the midbrain. And if that occurs and there's actually a hematopoiesis on the opposite side, that's called Weber's syndrome. So a lesion can occur in the midbrain, leading to cranial nerve 3 palsy. In the subarachnoid space, remember the oculomotor nerve goes through the subarachnoid space. You could get a posterior communicating artery aneurysm. Now, if that occurs, there may be compression on the oculomotor nerve, and that will lead to pupil involvement to the mydriasis. The reason being is because the visceral fibers, the parasympathetic fibers, actually are superficial. They surround the somatic fibers. So actually, on a compression by an aneurysm, those will be affected first. So that can lead to more pupil involvement in a posterior communicating artery aneurysm. If there's ischemia of the somatic fiber nerves, just ischemia, not compression, but ischemia of the nerve, then that is likely going to be pupil sparing. So pupil sparing, let me just write that more clearly. So that is pupil sparing. And it could be neoplastic infiltration. The oculomotor nerve goes through the cavernous sinus. So some possible pathologies there could be a meningioma, tumor of the meninges, schwannoma, or cavernous sinus thrombosis. And that may affect the abducens and the trochlear nerve as well. In terms of intraorbital causes, there may be tumors, and tumors presenting at the back of the eye may be associated with a proptosis, so a bulging out appearance of the eyes. You can get autoimmune causes such as myasthenia gravis, and demyelination causes such as multiple sclerosis. Someone with cardiovascular risk factors, they've got diabetes or hypertension or vasculitis, they may be at more risk, increased risk of oculomotor palsy because of damage to the nerves. So that gives an overview of oculomotor palsy, the presentation, and some of the main causes. Now, the next part of the video is going to look at the extraocular muscles and their actions. So I'm going to switch to a good animation here. So this is good at illustrating the extraocular muscles, and we can see them here. So this is the lateral rectus going over my cursor, superior rectus. Oh, let's go back. Yeah, so this is the underneath here, originating on the inferior part of the orbit floor, is the inferior oblique, inferior rectus here, and going through the trochlear is the superior oblique, and there's the medial rectus there. So this is another diagram from Moronega illustrating this extraocular muscles again. And we're going to keep referring to this table here, which we can give us the muscle actions for the different muscles. So all of them will have a primary action, a secondary action as well. Don't worry too much about the tertiary action. It's quite easy to make sense of it when we incorporate it all together. So the first two muscles, the medial and lateral rectus, are relatively easy. If you were to contract those muscles, those are just responsible for adduction and abduction. Medial rectus adduction, i.e. eye movement towards the nasal bone, and lateral rectus away from the nasal bone. Let's take a look at the superior rectus and the inferior rectus. So this is superior rectus here in the orange, and the inferior rectus in the pink. And the angle between the floor angle between the nasal bone and the insertion of the muscle is 20 degrees in both of them. So let's have a look at superior rectus. And these are really good diagrams to make sense of the action. So superior rectus attaches, there's a slight angle as to where it comes from the tendinous ring, and it attaches onto the actual eyeball itself. So let's say the eye is abducted. So the lateral rectus has done its work and it's abducted the eyeball, okay? If the superior rectus was to contract, what movement would be the greatest? It would just be simply elevation, because it's more or less, the contraction of the fibers is more or less in parallel with the gaze, where the eye is looking. And that diagram on the right is pretty much similar to this diagram here, because the eye is pretty much in parallel to the tendinous insertion. Let's take the example of now the eye is adducted. So the medial rectus has done some work, and the eye is facing inwards towards the nasal bone, so it's adducted. What would be the primary action of the superior rectus? Well, it wouldn't really elevate as much, but what it would do more intorsion. Because if you imagine here, if you're going to contract these fibers, these are going to it's going to draw the eyeball inwards towards the nasal bone. It's going to have some intorsion, and there's going to be adduction as well. So in adduction, the superior rectus primarily intorts. In abduction, the superior rectus primarily elevates. So that's why when we go back to the table, we can see that superior rectus, the primary action of it is to elevate, and that is best in abduction. But it also intorts, but the intorsion effect is greatest when the eyeball is adducted. Let's look at the inferior rectus now. The inferior rectus is here. It has a very similar insertion pattern to the superior rectus. So the inferior rectus is here. Now this time we're looking from below. We're looking from below. The last time we were looking from above. Let's take the scenario where the eyeball is abducted. So the lateral rectus has done some work and the eyeball is looking away. This is the nasal bone here. So the eyeball is looking away. And what would be the primary action? The primary action would be depression, because the gaze is more or less in parallel with the muscle fibers here contracting. It's going to primarily be depression. So when these fibers contract in the image, the eyeball will be looking directly towards us coming out of the screen. What about when the eyeball is adducted? So this time the medial rectus has done some work and the eye is more adducted, so it's facing towards, you're looking inwards towards the nasal bone. If you were to contract the inferior rectus, it would extort the eyeball. So in contrast to this, the superior rectus, it extorts the eyeball, not intorts it. So extortion of the eyeball. And you can imagine that here, because if you were to contract these fibers, the eye would move this way, and if you were to follow it up from the other side, it would be moving away from the temporal side. So extorsion of the eyeball. So you can imagine it moving around here. If you were to contract these fibers, moving round and over, and that would be extorting the eyeball. See if that would make sense on this diagram actually. So inferior rectus here. So on our scenario, we said that the eyeball was adducted, so if the eyeball was looking this way, then you were to contract the inferior rectus, it would extort the eyeball. I hope that makes sense. It might be hard to imagine initially, but it does make sense. Extorts the eyeball. Hope you can imagine that. So to conclude from inferior rectus, when the eye is abducted, it depresses the best in that position. And the inferior rectus extorts the eyeball best in adduction. And we can check that with our table. So that inferior rectus depresses the eyeball best in abduction and extorts the eyeball best in adduction. And the last two, these are a bit more complicated, but they're not really hard to understand if you get your head around them. So these got the superior oblique and the inferior oblique. Superior oblique comes through the common tendinous ring and it goes round the trochlea and attaches at the top of the eyeball. The inferior oblique originates on the orbital floor, anterior orbital floor, and comes up here and attaches on the lateral underside of the eyeball. So what would be the action? So we've got here the superior oblique, we're viewing it from above. Let's take the situation here on the right. So the eye is abducted. So the lateral rectus has done some work and is abducted. Now, when you contract the superior oblique, what would be the primary action? You primarily intort it. And we know that because if you look at these fibers, they're kind of almost perpendicular to the gaze. So it's going to pivot around the eyeball is going to pivot around the same gaze. So these fibers are going to contract this way, and we're intorting it. We're it's going to have an internal rotation towards the nasal bone, so primarily intorts, rolling towards the nasal bone when the eye is abducted. Let's take this example here. So this other situation would be if the eye is already adducted, so the medial rectus has done some work, and the eye is already adducted. What would be the primary action? The primary action would be depression of the eyeball, because if you were to contract these fibers here, the position of gaze is almost parallel to the fiber contraction, and it's going to pull the eyeball down. So the end result of this contraction would be this pupil is going to be going into the page, and we wouldn't be able to see it. All we'd be seeing would be the back of the eyeball. So it depresses the eyeball. So the superior oblique, just to conclude that, so the superior oblique intorts best when the eye is abducted, and it depresses best when the eye is adducted. And we can check that with our table here. So superior oblique intorts the eyeball primarily, but it does that best when the eye is abducted. And it also depresses the eyeball, but it does that best when the eye is adducted. So let's go to the final one. The final one is the inferior oblique muscle. And this is a view from below. So take this example on the right. So this example on the right, so this is the attachment at the orbital floor, and this is coming up to attach to the lateral side of the eyeball. So when the eye, this is the nasal bone, when the eye is abducted, so the lateral rectus has done some work, the primary action of the inferior oblique is to extort the eyeball, because if you imagine, we're looking from below, so these fibers are going to contract that way. It's going to, you know, this attachment here at the side is going to be dragged this way by this, because the origin is here, it's fixed at this point. So it's going to drag the eyeball this way, and because this is the temporal side, it's going to extort the eyeball. It's going to roll the eyeball away from the nasal bone towards the temporal side. Okay. In this situation on the left, when the eye is adducted, so the medial rectus has done some work and the eye is adducted, the primary action of the inferior oblique is going to be to elevate, because the elevation of the eyeball, look, if you can, this is the attachment to the eyeball here, and this is the fixed position. If you were to contract these fibers, then this pupil is going to be now going out of the page, you know, away from us. So because this is the view from below, you bring in the underside up. So when the eye is adducted, the inferior oblique primarily elevates the eyeball. So to conclude that bit, the inferior oblique extorts the eyeball best when the eye is abducted, and it elevates the eyeball best when it's adducted. And we can check that on our grid, and we got it here. Inferior oblique extorts the best when the eye is abducted, and it elevates the eye best when it's adducted. So that gives you an overview of the muscle actions, and we can relate that clinically to our test when we draw our letter H in the air for our patients. We use this H test to test the different muscles. So it's important to know, well, what are we testing when we point in different directions. So if we're testing this right eye here, if we were to move our finger to the lateral side away from the nose, you primarily just testing the lateral rectus. And when you move it horizontally into the medial side, you're primarily just testing the medial rectus, and that's easy. Now remember what we said about the inferior and superior oblique. Now this, when we're testing up and down towards the nasal side of the eye, that means the eye is adducted. So what do they do best in adduction? Well, we said this before. Maximal in adduction is depression for the superior oblique, and maximal in adduction for elevation is inferior oblique. And we can map that across, look, because inferior oblique, look at this, it's elevation of it, primarily elevating when the eye is adducted, and the superior oblique primarily depresses when the eye is adducted. That's why those muscles, that's why we test in those directions, we are testing for those muscles. And this side here, well, the eye is, because it's towards the temporal side, the eye is being abducted. So what muscles are primarily elevating and depressing when the eye is abducted? When the eye is abducted, as we can see from the grid here, when the eye is abducted, the superior rectus primarily elevates. And when the eye is abducted, the inferior rectus primarily depresses. And that's why when we test in that H towards the lateral side and up and down, we're testing the superior rectus and the inferior rectus respectively. So I hope that gives a good overview of the extraocular muscle actions as well as cranial 3 palsy and the extraocular nerves.